Welcome to Pharmacy Prep. Today I'd like to present you question alerts on antidepressants. Antidepressants is one of the important topic or major topic every student must read before you enter into the National Pharmacy Board exams. And among the antidepressants, often questions are expected, and those questions are often related to what are the most likely or least likely, or what are the highs and lows of antidepressants. Because most antidepressants have a similar efficacy, especially all SSRIs have a similar efficacies. However, when it comes to the selection of the drug for the treatment, primarily depends on the drug tolerance or patient tolerance to the drug. That means what drugs have the most likely a specific side effects, or what is the more better drug. It's selected based on the most and least drug effects. So therefore, here today's presentation is mainly focused on those high yield points that are highly expected in the exams. So today, first thing, I like to begin this topic with the most first line therapy of major depression, or the SSRIs. SSRIs. SSRI itself tells you that is selective serotonin reuptake inhibitors. Selective serotonin reuptake inhibitors, as the name itself tells you, that is, they are selective to serotonin. So being selective to serotonin, the advantage of these drugs is these drugs have a more better tolerance because of less side effects that are associated with the non-selective reuptake inhibitors. So that's the reason why SSRIs are considered as a better tolerating drugs for treatment of major depression and also for the treatment of anxiety disorders and also various other conditions. Well, from the SSRIs or from all antidepressants, the most often questions expected from the onset of these drugs, meaning the time when how long it takes to start showing the response of the drug. Generally, these drugs have a slow response, so therefore it takes up. If there's a question, I would go for this begins the effect from the 2 weeks. So initially, from various symptoms of patient symptoms, generally initial response seen in the insomnia, and also patient will have some increase in energy because these effects are first response with in the 1 to 2 weeks or from the 2 weeks afterwards. However, it takes about the maximum or optimal effects. Optimal effects takes about 4 to 6 weeks times. So that which is the best answer is 4 to 6 weeks for major depression and begins from 2 weeks. However, this 4 to 6 weeks time can be longer for anxiety disorders treatment. Anxiety disorders can take longer than 6 weeks to show maximal response. So those are the key points for onset and also the optimal effects. And the next one, the other important point that every student should know from the antidepressants, which is serotonin syndrome. Serotonin syndrome, as itself tells you, that it is related to excessive activity of serotonin. So that means when generally this can occur when there are two antidepressants are combined together, or this can occur due to the high dosages of serotonin activities. So this generally, it has been identified that especially in the serotonin receptors, among the serotonin receptors, excessive activity at 5-HT2A receptors, like 5-HT is a serotonin and 2A are the sub-receptors of this one. So 5-HT2A receptor activity are known to cause serotonin syndrome. So, in addition to this serotonin syndrome activities, one more important point is although it is a rare condition, but it can be identified if it is given in the case scenario, especially the symptoms. What are the symptoms that are associated with serotonin syndrome? There are several symptoms, but some symptoms are more important. According to there is a criteria that's called Hunter's criteria. The Hunter criteria has identified for the diagnosis or identifying if it is causing by serotonin syndrome. So generally, if it is a case scenario, you will see patient has the medication in the patient case. Obviously, patient medication profile consists of any drug that is antidepressant or serotonergic drug present in the patient profile. That can be a good clue. Or additionally, there are symptoms of serotonin syndrome can be a good clue as well to identify that patient may be experiencing serotonin syndrome. Generally, that could be case scenario questions. So in this case, I would say from the Hunter's criteria, which is used, can be used for diagnosis of serotonin syndrome. The classical symptoms or the hallmark symptoms are muscle spasm, which is known as clonus, spontaneous muscle spasm, and could be agitation or sweating or tremors, shaking, and also can be high temperatures like fever-like symptoms. Although it is not common, but there are other symptoms also include pupil dilation, nystagmus, and delirium. These are the classical symptoms of serotonin syndrome. So also questions can be also expected to have how to manage this. This is something can be lead to the serious complications. So therefore, it does require um, uh, intervention to minimize these complications. So that can be done by referring patient to the hospital, or in some cases that can be managed by medications. So the questions can be on medication management, such as using benzodiazepines or cyproheptadine, are known to have these medication use, some cases in a hospital, that are used for managing serotonin syndrome. Well, what kind of antidepressants are most likely associated with serotonin syndrome? Generally, MAO inhibitors are known to have a very high risk, especially when MAO inhibitors, such as non-selective MAO inhibitors like phenelzine, tranylcypramines, when they are combined with SSRIs, eventually can lead to the higher risk of serotonin syndrome. That's the reason whenever you are switching from MAO to the SSRIs, or the vice versa, which is SSRI to MAO switching, one may require to have a washout period just to avoid the risk of serotonin syndrome. So there are some drugs also have a less risk compared to the MAO and other ones, such as amitriptyline, which is a tricyclic antidepressants, amitriptyline, mirtazapine, and also trazodone. These three drugs have less risk of serotonin syndrome according to the references. So all this information has taken from the credible references. I'll be linking these references following the video. Those who like to look into the more details, you can definitely look at those information as well. However, this information is very high yield point, which is very effective and very refreshing. Even you listen this just before your exams. Well, this one, then after the um, onset and then serotonin syndrome, the next one, let's look at what are the complications of, what are the drug therapy problems, or what are the side effects of SSRIs. So here, the most common side effects of SSRIs are gastrointestinal side effects. Say, for example, the nausea. Nausea, here I have marked with the different identification of the drugs here. For example, nausea is 37%, means among the SSRIs, the highest nausea is associated with fluoxamine. This is the fluoxamine. Fluoxamine has a 37% nausea, and then followed by this, the other ones also have a pretty high percentage of the nausea. And the nausea generally can diminish over the 1 to 2 weeks. So, and until then, one can take this medication with the food or increase fluid intake. So by doing so, that can help to reduce the nausea symptoms. However, after 2 weeks, still not tolerable, then required to refer to the doctor to discuss about switching to the different class of different different antidepressants. So the other second important gastrointestinal side effect of SSRIs are diarrhea. Among the diarrhea, that is the higher risk of diarrhea is associated with the sertraline. Sertraline, the product name is Zoloft. Sertraline Zoloft, which is about 18% diarrhea. So same thing with the diarrhea as well. So one have to rehydrate well, and also make sure that if it is generally diminish within 1 to 2 weeks, first 2 weeks of starting this medication. If not improvement, then eventually required to change to the different drug as well. That's the best management for GI side effects that are associated with the SSRIs. The other GI side effect of SSRIs include the constipation. Obviously, the constipation is much common with fluoxetine, which is a fluoxamine. This is the fluoxamine, not the fluoxetine. Fluoxamine, which is this is also fluoxamine nausea as well. Here also it is a fluoxamine. Just correct that point, please. So those fluoxamine, which is 18%, there is a constipation is possible. So this fluoxamine, obviously constipation, again, could be a transient or can diminish in 1 to 2 weeks. However, this can be managed by increasing fluid intake or fiber, and in some cases it can require laxatives, especially if you're using for senior elderly person, there is higher risk of constipation with paroxetine. Paroxetine is a Paxil. Paroxetine is not a good option for elderly person because that is a higher risk of constipation as well. Well, therefore, some cases it is used less dose in elderly person, or look for different antidepressants in this case. So another rare side effect, which is SIADH, syndrome of inappropriate antidiuretic hormone. So in this syndrome, which is likely increase the risk of hyponatremia, it can increase the risk of hyponatremia, and this can be monitored because when there is a hyponatremia, that also increase the risk of falls because it can make person dizzy or can lower the blood pressure, and eventually can increase the risk of falls and fractures. So therefore, elderly persons who are taking these medications, if in that case they require monitor for sodium, because hyponatremia, sodium is a major one, other electrolyte as well, and just to minimize the risk of fracture, bone mineral density, which could be also a diagnostic test for screening test for the osteoporosis. So those are the two important points for elderly patients who are taking, especially this commonly the SIADH, which is a syndrome of inappropriate antidiuretic hormone, is associated with paroxetine. Also, there are reports with the other antidepressants. So in addition to that, other side effects that you should keep in mind, for all antidepressants have a slightly or weight gain side effect, about 5% over the 5-year period. It has been shown to have a 5% of weight gain. So if it is weight gain is an issue for the patient, that is then the best management is to switch to the different antidepressant that has a weight loss or no weight gain side effect. The best option can be a bupropion. That's another frequent question. Where I marked as a Q, there is a question possible, so I like to mark here as a Q. So this is a Q. The best option is if someone is complaining about weight gain and weight gain is a concern, then it is a good thing to switch to the bupropion because bupropion has the least side effect of weight gain or can have some weight loss as well. So then other side effects of SSRIs include the insomnia. Insomnia, which is more higher insomnia, is 16% with the fluoxetine. Fluoxetine, FX here is for fluoxetine, which is a Prozac. Prozac is about 16%, which is also sertraline as well, about 16% of the insomnia side effect. That means obviously that can diminish after 1 to 2 weeks of taking this medication. In that during this time one can encourage to have a sleep hygiene and recommend to take to this medication on the morning. So that could be an effective way to manage the insomnia coming with this medication. And then additionally there are somnolence. Somnolence is about the highest somnolence associated with fluoxamine. Fluoxamine sounds like a fluoxetine, but they are not the same. They're fluoxamine, which is less commonly used, which is a Luvox, whereas fluoxetine, which is a Prozac. They are two different drugs. So I'm talking about somnolence is higher with fluoxamine. They sound like drugs actually, although they look different spelling, but they sound like drugs. So generally, the somnolence also can be causing generally first 2 weeks, usually diminish after one to 2 weeks. It's a good idea to recommend to take at bedtime to minimize the risk of somnolence side effect with this one. And then another major side effect of SSRIs are sexual dysfunction, which is another frequent question. So as such, all antidepressants have a sexual dysfunction. And this sexual dysfunction is also associated with SSRIs and SNRIs. So, and the sexual dysfunction is, it is equal in the men and women, equal in men and women. And in generally men has ejaculation delays side effect. So in the best option to manage the sexual dysfunction is to change drug with the low sexual dysfunction side effects, because this sexual dysfunction side effect can remain till the person taking the medications. So therefore it's a good idea to switch to the drug that are less sexual dysfunction, such as bupropion. BU here is for bupropion, MZ is for mirtazapine, and valizidone and vorsaxetine. These are the 4 drugs have least sexual dysfunction side effect. So that's the best management. Or persons who have erectile dysfunction problem, they can be used. Sildenafil or PDE5 inhibitors can be used for managing sexual dysfunction side effect. So addition to this, other side effects of SSRIs include, some SSRIs have a stimulating effect. That means they do cause like anxiety, like fluoxetine. Fluoxetine, which is a Prozac, has about 12% anxiety. That's one of the high anxiety drug. And also agitation is possible with the fluvoxamine, which is a Luvox, about 16%. So you don't have to memorize the percentage here. I'm just giving this percentage based on the primary references data, comparing with the placebos. However, this is just I'm giving you this percentage just to retain in your mind what is the higher, what is lower. Because when I write all of them into the high, it is very hard to figure out which is the most and which is the least. So just to try to figure out which is the most and which is the least, I'm just giving you percentage, but I'm not hoping question could be asking what percentage is the answer. So therefore, it is just to give you idea. However, all my recommendation is a personal information. I'm just giving you a clues how to figure out the best answer. This information is not for practice, not for any other use except preparing for your exams. So here, in case if someone is experiencing anxiety or agitation, generally that can remain first 2 weeks. And after that, one may require to, in case some cases may require benzodiazepines, then you can give it for short time use. And in case if agitation is very severe and eventually that is an indicator that patient is not tolerating this medication, so in that case, patient may need to change to the different drugs of the different class which has a less agitation. Luckily, not many SSRIs have agitation, but can be switched to the different SSRIs. So when it comes to the two drugs, one is a citalopram and escitalopram, escitalopram, that's called so many ways. But I would say citalopram and escitalopram. So these two drugs are citalopram here, which is Celexa, and escitalopram, Lexpro. So citalopram is a racemic mixture, which is a racemic mixture of R and S isomers, whereas S-citalopram, which is the S-citalopram, which is written as a ES, but you can say S-citalopram. So S-citalopram, easy to know that it is the S isomer of citalopram. So that means these two drugs are chemically related except their isomers. So since S-citalopram is a pure isomer, it is a more potent compared to citalopram. So the dosing will be less because of the potency. So when I say potent, doesn't mean that is more better than others. However, it has more less dose, it does produce same response. So whenever it does have these two drugs, whenever you think of citalopram and escitalopram, which is important that these two drugs have a higher risk of QT prolongation side effect. So this QT prolongation side effect obviously is a major concern, especially when it can lead to the drug interactions, especially like there is a, according to the FDA categories of drug interaction, citalopram and quetiapine has category C drug interaction. That means one may require monitoring if they are combined these two drugs, because quetiapine, which is an antipsychotic drug, also can cause QT prolongation, and including macrolides such as clarithromycin, fluoroquinolones, especially moxifloxacin, and gutifloxacin as well, not given here, but gutifloxacin is withdrawn. So therefore, these are the drugs that you may require to watch out for their QT prolongation side effects, especially when they are combined together. And also one more important point for these drugs is because of the risk at the age 65 and older, citalopram maximum dose should be 20 milligram is max dose is used for elderly persons, whereas escitalopram is max dose for over 65 is 10 milligram dose. So a lot of times students ask like, do we need to memorize the dosages for the exam? Well, I would say yes. Some cases dosages plays very important role that could be can lead to the high dose of citalopram for over 65-year age can lead to a drug therapy problem. So therefore, such kind of dosing are important that everyone should know before you step into the exam. So these are some of the summary of the SSRI's side effects. So let me go over other points here. So as I mentioned before, so already we discussed about serotonin syndrome. You can see here serotonin syndrome, which can lead to the combination SSRI combined with MAO inhibitors and tricyclic antidepressants and the triptans. Especially triptans are very important. Someone could be having a migraine case, patients taking migraine and now also have been prescribed some antidepressants. So it can lead to the, especially among all triptans, not all triptans have the serotonin syndrome, but some of them, yes, like sumatriptan is known to have the interaction with the triptans to SSRIs or according to FDA category, which is known as category D interactions. So that means this, whenever it is according to FDA, if it is a category D interaction, a drug either require modification, dose adjustment, or changing to the different drug required because of those severity of the drug interaction. Well, most important interaction that is expected in the most exams are dextromethorphan. Dextromethorphan, which is an over-the-counter cough suppressant or cough suppressant. So dextromethorphan, which is chemically structurally related to opiate, so therefore it can lead to the serotonin syndrome because it will also have some effect on serotonin receptors. As a result of that, dextromethorphan can lead to the serotonin syndrome, and especially there is a higher warning with MAO inhibitors. So that means if person is taking any MAO inhibitors or including SSRIs, dextromethorphan is not used along with this one. So therefore, either change to the different cough suppressant or have to watch for the patient any risk of serotonin syndrome. And among the another important class of drug that is known to have serotonin syndrome are opiates. So among opiates, not all opiates have a higher risk, but some opiates have a higher risk of serotonin syndrome than other drugs. Like for example, tramadol. Tramadol is mechanism-wise, partially it also acts on the mu receptors. It is a mu agonist, plus also it does inhibit serotonin reuptake and norepinephrine reuptake. So because of that, tramadol, which is a opiate class of drug, and that can lead to the serotonin syndrome if it is combined with SSRIs. Same thing with the meperidine and also fentanyl. Fentanyl also can lead to those drug interaction with SSRIs. So often, very frequent question on the drug interaction with the SSRIs is a natural product, a herbal product that is called Saint John wort. So this Saint John wort, which is a natural herbal product, and also sold in the market as a treatment for major depression or depression disorders. So therefore, since it is available over the counter, patient could be using it, and that has a higher risk of serotonin syndrome. So therefore, although it is according to the FDA, Lexi Interact, because I use this tertiary reference to check the drug interaction. So therefore, I would rather just referring to the reference. So sometimes those tertiary references may not be as accurate as primary, but that's easy to access that information. So according to the Lexi Interact, the interaction of the St. John wort with the SSRI is a category C interaction. So category C means one can require to monitor. However, it says higher risk. So therefore, it is required to make a professional judgment to avoid using them because that can increase the risk of serotonin syndrome. And also the methylphenidate stimulants or amphetamines are known to have increased risk of serotonin syndrome when they're combined with the SSRIs. So most of the questions are goes around the serotonin syndrome, what drugs or symptoms, or what are the basis of serotonin syndrome. Otherwise, other drug interaction or NSAIDs. NSAIDs with SSRIs increase the risk of GI bleeding. You wonder how come NSAIDs and SSRI combination can have an increase the risk of GI bleeding, because there are serotonin receptors in the gastrointestinal tract known to cause this risk of GI bleeding. So therefore, whenever NSAIDs and SSRIs are combined, there is a higher risk of GI bleeding, which is according to the FDA, which is a category D interaction. That means that may require dose modification or may require some sort of adding proton pump inhibitor as a protection, which is something often question can be expected on those two case-based questions are possible. So either you can add PPIs or change to different pain medication. So acetaminophen can be a good option if someone cannot tolerate NSAIDs or higher risk of GI bleeding. So, and other important drug interactions is CYP2D6, because fluoxetine, which is a Prozac, right, FX. The Prozac has, Prozac is a strong 2D6 inhibitor, 2D6, CYP2D6 inhibitor. And there are CYP2D6 medication substrates such as codeine, for example. Codeine is a CYP2D6 substrate because codeine have to be activated to become morphine, and this codeine become morphine by CYP2D6 enzyme. That means codeine is a substrate of 2D6. So codeine turns to the morphine. So this codeine turns to the morphine by CYP2D6. So now this 2D6, obviously if person is taking these two combinations, eventually 2D6 inhibitors such as fluoxetine can lead to the drug interactions. In addition to that, this CYP2D6 is a type of a pharmacogenetic, meaning there are some patients are fast metabolizers and slow metabolizers and normal metabolizers. So therefore, if someone has the fast metabolizers of CYP2D6 or slow metabolizers, then eventually can lead to the more serious drug interaction. So therefore, that is the one point that one should keep in mind when you're looking at the 2D6 interactions. Among other, compared to other antidepressants, the fluoxetine has a more potent 2D6 inhibitory effect compared to other antidepressants. Other antidepressants have a less effect on 2D6, CYP2D6. So next we talk about the other important point that every student must know before you get into this exam, pharmacy exams, is there is discontinued syndrome, also known as withdrawal symptoms. So obviously SSRIs, if someone suddenly stop taking them, can lead to the sudden withdrawal symptoms. And those symptoms generally can begin within 1 to 7 days. So that means one should not stop them suddenly. One have to gradually taper them, right? Generally, it is recommended to taper 25% of the dose per week. So therefore, that's the right way to stop it. But if someone stopped taking it, or for some other reason, someone suddenly stopped taking it, one may experience such as change in the mood, dizziness, nausea, and these are the classical symptoms, or insomnia, and also can lead to the sweating. So those are some of the symptoms that are associated with the discontinued syndrome. So among these discontinued syndrome, there are also other important point is There are drugs that have a long half-life, like SSRI. Among the SSRIs, the longest half-life is with fluoxetine, which is a Prozac. The brand name is Prozac. So the fluoxetine has about close to longest half-life. So about 5 weeks of half-life, because it makes the norfluoxetine and various other metabolites, and those metabolites have a longer half-life. Eventually, therefore, it is considered as the longest half-life SSRIs. So what is that being a longest half-life? So what is the advantage of this drug? Obviously, this will have less withdrawal symptoms. That means one can taper that rapidly. Means here you're tapering 25% per week. So this can be a higher percentage or shorter time to can be tapered. This so that means those are the one that is a key important point that for often question on that one point, that is what drugs require. For example, just give me here, obviously fluoxetine. Where there is a, I'm going to put it Q here. Where there is a Q, there is a more potential question. That means there is a question is possible on those fluoxetine. So whereas paroxetine, which is a Paxil, obviously the paroxetine has the shortest half-life among the SSRIs. So what is being a shortest half-life means if someone even skip 1 or 2 days dosages, then eventually person can start seeing those withdrawal symptom or discontinued symptoms. So these are the key points related to SSRIs. So now, after this SSRI, let's move on to the next, that is another class of antidepressants, SNRIs. Next is SNRI. So SNRI, serotonin, norepinephrine, reuptake inhibitors. So what you see the difference here compared to the previous one, that was the SSRIs. So SNRIs are also have effect on serotonin and additionally on norepinephrine. So that means it is a type of dual acting reuptake inhibitors. So because of that dual acting reuptake, so there are some advantages and also there are some disadvantages of these medications. The advantages is because of this norepinephrine effect, often this is also used for various, these medications also used for various neuropathic pains or neuralgias like diabetic neuralgia, fibromyalgia, or post-herpetic neuralgias. Those are the medications and also used for that because of those norepinephrine effect. And then the downside of that effect is especially for venlafaxine. Venlafaxine, which is a Effexor, which is higher dosages. If it is used more than 225 milligram dose, that means if it is a more than 225 milligram dose, then at this dose, it does also affect on norepinephrine. So as a result of that, since it does increase the norepinephrine, there is an increase in the hypertension is possible. That means it can cause dose-dependent hypertension. So therefore, initial dose should not start with the high dosages for venlafaxine. And generally, it comes into the low dosages like 35 milligrams, like 75, 150, etc. So in that case, generally should be start with the low dose, and if you're going higher dosages, then obviously it is considered as more risk of having hypertension with venlafaxine. Whereas the other medication in this class of SNRIs, or very popular one, is duloxetine. Duloxetine, the product name is Cymbalta, and this duloxetine, obviously, which is mainly, as the name tells to do, is for two, it acting on serotonin and norepinephrine as well. However, it does works on the fixed dose, And then it is also addition to since it is not used in the high dosages, a lot of time it is used in the low dosages for the neuralgias and also fibromyalgia and other neuropathic pains. So additional to this, there's other additional side effects of these class of drugs also include the insomnia. For example, these could be slightly stimulating, which is 17% is when venlafaxine has about higher insomnia compared to duloxetine. So in case of duloxetine, if you have to know one thing which is very specific to duloxetine is it can cause the liver enzymes increases. And therefore, patients with the liver diseases, duloxetine is not used. And also it is contraindicated in patients who have an uncontrolled open angle glaucoma. And also the renal disease, patient who have a renal function less than 30 mils per minute, then it is not a good one to use it. So other side effects of SNRIs include the somnolence, which is fluoxetine has about 17% of somnolence. As a result of that, if person is experiencing somnolence with venlafaxine, obviously you have to go give it at bedtime. Otherwise, it is given in the morning. So this could be a patient specific. If someone is experiencing insomnia, you could recommend to take it morning. If it is experiencing somnolence, can go for bedtime. So in that case, generally these side effects can diminish after 1 to 2 weeks of taking the medication, but if not, eventually required to change this medication to the different class of different medication. So another side effect, GI side effect, is constipation, which is obviously can be more with the venlafaxine compared to the other medication in this class. So there is one desvenlafaxine, which is a Prestige. Desvenlafaxine is a isomer or active metabolite of, sorry, not the isomer, active metabolite of venlafaxine. And since it is a active metabolite, which has a 50 milligram is more potent, it has a higher potency compared to other drugs in this class. And one more important point about the the duloxetine is duloxetine has a stronger interaction because duloxetine is a substrate of CYP1A2, and this CYP1A2 is not that very common CYP enzyme, but this drug has a very high interaction. And there are strong inhibitors such as ciprofloxacin and fluvoxamine. Those are the medication, those that can lead to the severe drug interaction. I haven't checked the category severity, but you can consider that as a good potential interaction with this one. So addition to this, other points in the SNRIs are pretty also first line therapies as for SSRIs. And also the venlafaxine also has other uses. For example, in postmenopausal women who are unable to take estrogen because of the breast cancer, this can be also used for treating menopausal symptoms of hot flashes or vasomotor symptoms that are associated with the menopause. Otherwise, there are many other therapeutic use, and also SNRIs are the first line therapies for major depression as well. So the next other class of medications from the antidepressants are very popular one is another dual acting ones is called NDRI. NDRI, which is a norepinephrine dopamine reuptake inhibitor. So what that means is this class of medication has less effect on serotonin. So rather more they are norepinephrine and dopamine reuptake, which is a much different than other previous class of medications. So the most popular in this class, obviously only one right now, which is the bupropion. Bupropion comes into the two brand names. One is a Wellbutrin. Wellbutrin is prescribed for major depression treatment. And then other one is Zybon. Zybon is used for treating smoking cessation. So that means bupropion has a very special use compared to other antidepressant that is used for smoking cessation, which is we haven't seen from SSRIs or SNRIs. None of them have been used for smoking cessation. But there are so many advantages of bupropion. Is known for many things, such as it has the generally it is considered as the least weight gain. It's not mentioned here, but remember that this is considered as the least weight gain or weight loss, can be weight loss sometime. So for that reason, patients who are experiencing weight gain with the SSRIs, this can be a good option for those patients. Or this is another important thing is this has a also known for less sexual dysfunction. So these two are major advantages of bupropion. So less sexual dysfunction and also the less weight gain. So this is often this medication is switched if patient is not tolerating with the SSRIs and SNRIs, because SSRIs and SNRIs, both of them have known to have sexual dysfunction side effects in men and women. In such cases, the best switching medication is bupropion. So the bupropion is a good option in that case. So addition to that, there is other important thing that one should memorize about the bupropion is contraindicated or not used in patients who have a history of seizures or currently experiencing seizures. That means it can cause higher dosages. It can have a dose dependent seizure side effect because it decreases the seizure threshold. So therefore, it is something known for this contraindication. And also, bupropion is not used, also not used for patients who are having anorexia because of the weight loss issue here. So bupropion, which is contraindicated here, I write bupropion is contraindicated in bulimia and anorexia. Bulimia and anorexia nervosus. Those are the another condition that is bupropion is contraindicated. So another important point about is since it is having a effect on NDRI, so it has a stimulating effect. It can causing insomnia, and also it can increase the heart rate, and therefore since it has no effect on serotonin, so generally or less effect, generally considered as less effect or no effect. That's the reason why this medication is not used for anxieties. So it is not used for the anxieties. So this is something one key point that you have to know, familiar with the NDRIs. And then in this case, additionally here you have next other class of medications include the mirtazapine. Mirtazapine is very unique medication, and mirtazapine is basically it acts on alpha 2 antagonist, and also it has additionally 5-HT3 and 5-HT2 inhibitory effect, which is very unique class of medication, which is also known as serotonin antagonist or serotonin selective alpha 2 um, antagonist medication. So what that means is since it is inhibiting the alpha 2, which does increase the norepinephrine effect, and that helps to improve the mood. So that is therefore that helps in improving the use for treating the depression. So what is the negative points or what is the downside of this medication? The downside of this medication has very high weight gain, And also it has a very high activity on H1 receptor, and since it has a very high activity on H1 receptor, which is often lead to the high sedation. So therefore, it is also prescribed for treating insomnia. The low dosages, it does works on H1 receptors because of that H1 activity. And it has about 54% of somnolent side effects, so therefore it is recommended to give it bedtime. And the advantage of this one is this medication has the least nausea, vomiting, or nausea and insomnia and anxiety side effects because this is acting on 5-HT3 inhibition. That 5-HT3 inhibition, which is like works like similar to cetrans, like cetrans are 5-HT3 receptor inhibitors. So that means this can be used. This is considered as one of the least nauseating side effect drugs. So if someone is experiencing nausea and also this can be a good option. And also this is known to have mirtazapine, which is product name is Remeron, which also comes in the rapid dissolving products, Remeron RD. And these medication, mirtazapine, also have a less sexual dysfunction side effect. And as a result of that, that can be a good alternate to switch patients who are getting sexual dysfunction with SSRIs or SNRIs. Right after this, the important class of antidepressants are serotonin modulators. So these serotonin modulators there are three drugs in this class. One is trazodone, vilazodone, and fluoxetine. These three drugs belongs to the serotonin modulators. That means basically they do modulate. What that means, modulator? Like unlike reuptake inhibitors, they in the postsynaptic 5-HT receptors, they antagonize these 5-HT receptors in the postsynaptic, and they have a very weak 5-HT reuptake inhibition compared to other one. So although these medications have a very unique mechanism of action, so therefore they do have some very specific therapeutic uses, and also there are downside side effects. The advantage of trazodone is trazodone also has a daytime sedation. So therefore, it can be obviously, since having a good sedation, sometimes patient is used instead of patient who cannot tolerate benzodiazepines. In those patients, these medications are used for the treating insomnia, and especially that is used in hospitals. And they have a very strong effect on alpha-1 inhibition. So therefore, they can cause severe orthostatic hypertension, and that is because of alpha-1. So therefore, expect questions. Sometime question could be why, what is the cause of hypertension? So it is relating to the receptors is very important to understand the better physiological response of these drugs. So therefore, the questions can be asking indirectly what receptors are responsible for producing this orthostatic hypertension side effect. So addition to this, there are other like vilazodone, which is another medication of this serotonin modulator. In this vilazodone, most common GI side effects include the diarrhea, which is around 29%, and headache also possible, pretty high side effects. So therefore, to avoid that GI side effect, one have to titrate the dose or take with the food. Taking with the food enhances the absorption of vilazodone. So therefore, that's a good one. And fluoxetine, sometimes this is also placed in the SSRI class, but mechanism-wise, it can be placed in the serotonin modulator. So therefore, this one has a very high nausea, like other SSRIs, 23% nausea. So obviously wait for 2 weeks, and if not tolerating, then eventually need to switch. So the advantage of this medication, like vilazodone, is it has a less sexual dysfunction compared to SSRI. This can be one of the medication that can be switched for in case the patient is experiencing any type of sexual dysfunction side effect with this one. Then comes to the other important class, the old class of the antidepressant is tricyclic antidepressants. Tricyclic antidepressants are pretty older than SSRIs. In late 80s, these medications were actually first-line therapy for major depression. But now, because of the more better tolerability of the SSRIs has become a first-line choice. Since the use of the tricyclic antidepressants have significantly reduced, so these medications, instead now they are more popular for other therapeutic use. Like, for example, amitriptyline has severe, these medications have a much more anticholinergic side effects. And because of that, this medication have other uses as well. This can be used for migraine prophylaxis, and also can be used for neuralgia, neuropathic pain, and also other things that are other therapeutic uses. However, it is second line therapy for major depression. So most commonly expected question from the tricyclic antidepressant is the toxicity of amitriptyline, because amitriptyline overdose is the major one concern here. That's one of the reasons why these medications are not a first line choice, because higher dosages it increase the risk of cardiotoxicity. So the toxicity, the question can be what kind of toxicity that is expected from this one. So it is these medications are pro-arrhythmic, means it does cause AV node arrhythmias. So that's a very specific point that you have to know. So these AV node arrhythmias are main toxicity of uh, tricyclic antidepressant. That include it can cause sinus tachycardia, hypertension, orthostatic hypertension is possible. So these are the major side effects of these toxicities. So toxicities are one of the reasons why these are considered as not a great drugs for first line therapy. But when it is used for neuralgias and other types of other uses, amitriptyline is generally given in the low dosages, which is somewhere from 25 to 50 milligram dose, nighttime sedation dose. So therefore, it is one of the reasons why, which is low dosages are safer compared to the high dosages. Whereas the another drug in this class, that is nortriptyline. Nortriptyline is a secondary amine, which is a metabolite of amitriptyline. So amitriptyline is a tertiary amine, whereas nortriptyline is secondary amine. So being a tertiary amine, amitriptyline generally gets into the crosses the blood-brain barrier. It can cause more blood-brain CNS side effects or toxicity. Also has amitriptyline has a higher effect on norepinephrine, therefore has a more anticholinergic side effect as well. So that's one of the reason the nortriptyline been used quite some time before, but recently not that commonly used. But chemical structurally they are same, but only difference is the secondary amine. So clomipramine is another drug in this tricyclic antidepressants that is one of the known to have a higher serotonergic effect among the TCAs, and that's one of the reasons why this is used for anxiety, especially obsessive compulsive disorders. In obsessive compulsive disorder, this is a second line choice for treating OCDs, patients who are using this clomipramine. And then other ones are doxepine. Doxepine also has a much more effect on histaminic effect, and it's kind of dual acting. It also acts very high on the antihistaminic effect, plus also has a tricyclic antidepressant effect. So for that reason, sometimes that is used for insomnia as well. So those are the classical comparisons of these TCAs. However, anticholinergic side effects are the big ones that you have to keep in mind, especially if there is a toleration is going more than blood vision, then we need concern. And most frequent question from TCAs that is expected is obviously overdose toxicities. How to manage them, or what are the concerns and what are the symptoms that tells you that person may be experiencing overdose toxicity. So also just remember, we can also add one more overdose symptom here is mydriasis, which is opposite to whenever mydriasis. So for example, if patient is taking um, um, opiates and also tricyclic antidepressants. Now, in that case, if person is don't know what overdose patient is experiencing, so that can this mydriasis and myiasis can differentiate that patient is experiencing. If patient is experiencing mydriasis, then that could be coming from the toxicity of amitriptyline, whereas opiate toxicity can cause myosis or pinpoint people. So finally, we have the last class of medication, that is older drugs of this class, that is a MAO inhibitors. So the MAO inhibitors are, although very less commonly used, which is a third line option or last option. If no other antidepressants are effective, then this can be considered. However, exam questions are very common from the MAO inhibitors, although it is not very popular in use, but question-wise is very popular in the exam because it has a serious drug interaction, which is considered as serotonin syndrome. And then addition to that, this also has hypertension crisis, especially if it is taken with tyramine containing food. What does that means, tyramine containing food? Tyramine containing foods are those foods that are containing fermented foods, right? Those are the fermented food like cheese, wine, etc. Those do are fermented. So therefore they do have tyramine higher quantities, and that tyramine plus using any of the especially non-selective MAOs such as phenelzine and tranylcypromine, which is two of them are very important drugs in these old drugs. So if someone is taking these medication, then eventually it can lead to the hypertension crisis. What does that means is hypertension shoots up, blood pressure shoots up, means can lead to the too much blood pressure. So especially therefore that should not be given together. Say for example, cheese like pizza. If someone had a wine and pizza plus also taking this medication, phenelzine or tranylcypromine eventually can lead to the severe blood pressure. So therefore, that's one of the major drug interaction, addition to the serotonin syndrome as well. However, there's more popular in this class, that is a selective MAO inhibitors, which is MAO A selective, which is a moclobemide. Moclobemide is a second line choice for the treatment of major depression. The advantage of moclobemide is moclobemide does not have that similar type of hypertension crisis side effects as that's seen with other non-selective MAO inhibitors. Also, just to alert you that there are other MAOs that are used for selegiline and resegiline, which is used for the treating Parkinson disease, mild Parkinson disease. Those are not related to this class. However, they are MAO selective B inhibitors, which is slightly different receptors compared to this one. So just to mentioning not to confuse with those selegiline and resegilines. Well, on top of this, the frequently with this MAO inhibitors, I was mentioning hypertension crisis. With this, one thing often expected question is sympathomimetic. Like for example, oral sympathomimetic, which is pseudoephedrine. Pseudoephedrine with the MAO is category X interaction. That means sympathomimetics plus pseudoephedrine can suddenly shoot up the blood pressure. So for that reason, MAO and pseudoephedrine orally is completely no-no. Whereas nasal drops of oxymetazoline with moclobamide also no-no, category X. Means these are the FDA, category X means completely no-no. And then addition to this, pseudoephedrine and SSRIs also have no interaction. That is very surprising. So that means that can be used together. So these are some of the key points. So now let's look at some case scenarios and questions. So that's the way our class lectures goes on at Pharmacy Prep. And this same lecture now also available into the podcast, which is a prep talk podcast that is offered here at our Pharmacy Prep. Those who want to just listen without seeing the video, you also have access to that one. You can always look into that as well. And also this information also we do promote onto the various platforms, social media platforms, YouTube and other ones. Please do feel free to access this one. And please do have your comments, and we really appreciate your feedback. And before we finish this one, I like to just give you a heads up on one simple case scenario just to see how do we proceed in our preparation at Pharmacy. So here is the one case I like to just quickly discuss. So this is in our online platform, Pharmacy Prep online platform. We have one very high-tech platform, which is the ePrep station. In this one, chapter-wise, we have a question bank. So here I like to present you a simple question related to major depression and bipolar disorder chapter. So here, if you look at here, there's a question is about patient with the major depression, and they have given the lab values and etc. So it's first time user new prescription filling for major depression, which is a fluoxetine 20 milligram once daily. So in this case, simple question is optimal response. The clue here is you have to look at question is asking how long it takes maximum effect. So the best time for the major depression, this is used prescribed for major depression. So therefore, the maximum response for major depression is 4 to 6 weeks. So that answer of this case can be presented here in the answer. If you click this answer, you will find the answer and also the reference for those answers. And however, the same question, if I change to the anxieties, you can have a longer time, 6 to 8 weeks time to show the response. So here you have a followed by this same case. So after 8 weeks, doctor was to mean there is no response. So if there is no response after 6 weeks or 8 weeks, then obviously it is a good idea to change to the different antidepressant from the other class. So therefore, the best drug here is other class is bupropion. So bupropion can be best answer for this case. So like this, we have several cases that are very potential, very relevant to your exam preparation. So therefore, please feel free to enroll in our courses, and also definitely it helps you to pass your exams. And I really appreciate and thank you for your time, and look forward to see you soon.